Assalamu alaikum wa rahmatullah. This is Sukaina AlHaddad, postgraduate year 2 dermatology resident to join dermatology residency program. Yes. It's definitely my pleasure to be part of the dermatology webinar organized by the Dermatology Students Club. I would like to welcome you all, my fellow pre- and postgraduate medical students. May Allah ease the rest of the journey for you. And my talk today will be, inshallah, about atopic dermatitis. So we will go through an overview about the definition and the epidemiology of atopic dermatitis, the etiology and pathogenesis, the clinical features, diagnosis, and management. So why atopic dermatitis is important? It's the most common chronic inflammatory skin disease, and its increasing prevalence presents a major public health problem worldwide. The characteristic features of atopic dermatitis include pruritus and a chronic or chronically relapsing course. It's usually beginning during infancy as early onset disease, however, occasionally first developing in adulthood as a late onset disease. It's important to hint here that early onset disease usually starts in the first 2 years of age, and it's the most common type of atopic dermatitis. However, about 60% of infants and young children with atopic dermatitis usually go into remission by 12 years of age. However, the late onset disease is much less common. It usually starts after puberty, and it's most common in women than in men. So atopic dermatitis is one of the spectrum of atopy, so it's often accompanied by other atopic disorder, such as allergic rhinoconjunctivitis, asthma, food allergies, and less often esophagitis. These conditions may appear simultaneously or develop in succession. Atopic dermatitis and food allergy are most likely for infants and young children, while asthma favor older children and rhinoconjunctivitis predominate in adolescents. So this characteristic age-dependent sequence for atopic conditions is termed the atopic march. And from the atopic march here, given the atopic disease progression that starts with atopic dermatitis, the management should not be concentrated solely on the acute flare treatment. Rather, it should be directed toward ameliorating the underlying genetically determined epidermal barrier dysfunction and to prevent active dermatitis via maintenance therapy. And this will be the concentration or the focus for our talk today. So we'll have a brief hint about the etiopathogenesis. It's a atopic dermatitis has a multifactorial etiology with a combination of genetic susceptibility and environmental factor contributing to the disease development. Defect in the skin barrier function, in addition to immune dysregulation following allergen exposure, are the key components in the development of this disease. So the main two components are defect in the skin barrier function and immune dysregulation following allergen exposure. So as you see in the picture here, we have impaired stratum corneum barrier function, and this is due to loss of function mutation in the structural protein filaggrin, and a skin defect and the extracellular lipid, including ceramide, in addition to loss of expression of antimicrobial peptide and serine proteases inhibitor. All of these factors will predispose the affected individual to less effective mechanical barrier against environmental factor, which may lead to penetration across the skin barrier, increased damage to the epidermal barrier due to scratching and proteases, and activation of the immune response. Subsequently, we will have immune dysregulation that results in both innate and adaptive immune response. So the immune response is illustrated more in this slide, which will show the acute and the chronic phases of IgE and T-cell mediated atopic dermatitis. So in the acute phase, we have predominance of T helper 2 response, which is mediated by interleukin 4, 5, 11, 13, and 31. While the chronic atopic dermatitis phase will have a switch from T helper 2 response to T helper 1 predominated response by interferon gamma, interleukin 5, and interleukin 31. So it's important to maintain in your mind that there are two categories of T-cell mediated response. One facilitating the acute atopic dermatitis phase, which is T helper 2 response, and one the chronic atopic dermatitis phase, which is T helper 1 response. Now talking about the clinical features. The clinical features can be classified based on the duration of symptoms or based on the onset of symptoms. So here we have three categories: acute, subacute, chronic. The acute lesion usually predominates the infantile atopic dermatitis. They are characterized by edematous, erythematous papule and plaque that may exhibit vesiculation, oozing, and serious crusting. So as you see in the picture here, we have infantile atopic dermatitis on the face, presented as erythema, scale, crust on the cheeks. It's important to hit the sparing of the central face here, while picture B shows more extensive disease with accentuation of a scale crust around the mouth. Here are the clinical features, just transitional zone between the acute, the subacute is transition between the acute and the chronic phase of atopic dermatitis. A display erythema, scaling, and variable crusting. The chronic lesion, it's usually happened in adolescent adult atopic dermatitis. To present as a lichenification, scale, and punctate exaggeration and the antecubital fossa with prurigonodule-like lesion. So as you see here in the antecubital fossa, we have the lichenification, scale, exaggeration. While here we have coalescing papule and lichenification on the ankle. It's usually due to chronic scratching and rubbing of the skin. And in the third picture here, we have thick eczematous plaque with exaggeration on the dorsal hand and wrist. So what we passed is the acute, subacute, and the chronic clinical features of atopic dermatitis. Here, based on the age of onset, we have infantile atopic dermatitis, which usually occur in less than 2 years old, typically develop after the second month of life. As mentioned in the acute lesion, often initially appearing as edematous papule and papular vesicles on the cheeks with a sparing of the central face. However, it may evolve to form large papules with oozing and crusting over the mouth. The second category is childhood atopic dermatitis, which range from 2 to 12 years old. The lesion in this category tend to be less exudative and often become a bit lichenified. The classic sites are the antecubital and popliteal fossa. So the distribution will be in childhood atopic dermatitis as flexural distribution. And other common locations include the wrist, hand, ankle, feet, neck, and eyelid. Any area of this area can be involved, and xerosis typically become more pronounced and widespread than infantile atopic dermatitis. However, in adolescent atopic dermatitis, which usually occur after puberty or after 12 years of age, it's featured subacute to chronic atopic dermatitis. So we will have lichenified lesion. Involvement of the flexural fold will continue as well. However, the clinical picture may also change. So they may have acute flares amiding the chronic phase of the disease. The last category is senile atopic dermatitis. It's usually occurring in people more than 60 years of age. It's characterized by marked xerosis. Most of these patients do not have the lichenified flexural lesion typical of atopic dermatitis in children. So the screaming feature will be the xerosis in people older than 60 years old. There are associated features that may hint toward or support the diagnosis of atopic dermatitis. So they may not present in all patients, but if they are present, they are supporting the diagnosis of atopic dermatitis. It's much easier if you memorize them in head-to-toe fashion. So when you see a patient with atopic dermatitis, you can just screen the patient moving from head to toe. So starting by the face, we will have loss of the lateral eyebrows, followed by Denny-Morgan folds or atopic pleats in the lower eyelids. Then we have periorbital darkening, or what's known as allergic shiners, which is gray to violet brown edema periorbitally. We might have central facial pallor, pityriasis alba. Pityriasis alba, usually it's located in the face, especially the cheeks. However, it can appear in the upper trunk. It's most obvious in individuals with darkly pigmented skin following sun exposure, and it's results from low-grade eczematous dermatitis that disturb the transfer of melanosomes from melanocyte to keratinocyte. So what we will see is hypomelanotic, ill-defined hypopigmented macule with fine scales. We have keratosis biliaris, which presents as keratofollicular papule with erythematous rim and the cheeks. Post-inflammatory hyper or hypopigmentation after the acute phase of the disease or the active phase of the disease, we will have follicular prominence. Similarly, it's most remarked in people with dark skin, palmar and plantar hyperlinearity, xerosis, and ichthyosis vulgaris, mostly marked on patients with filaggrin mutation, which will lead to decrease in the filaggrin on the skin barrier. There are variants of atopic dermatitis, or we can say they are localized variants of atopic dermatitis. So we have over the lips, cheilitis sicca, it's usually dryness or chapping of the vermilion lips. It's sometimes with peeling and fissuring. It might be associated with angular cheilitis as well. It's usually due to the repeated licking of the lips done by the patient to moisture their lips, which in turn may irritate the skin around the mouth and result in a lip liquors eczema. The second picture manifests ear eczema, which presents as erythema, scaling, and fissure under the ear loop and in the retroauricular area, sometimes in association with bacterial superinfection. Eyelid eczema, most common in adult atopic dermatitis. It can present as a sole manifestation without any associated eczematous features. So in contrast to eyelid eczema due to other causes, it's characterized by lichenification of the periauricular area as here. We have head and neck dermatitis, hand eczema, and juvenile plantar dermatitis. It's present with a glazed or edema scale and fissuring on the plantar aspect of the feet bilaterally. Here we have dyshydrotic eczema. This may appear on the palm or side of the fingers as a deep-seated vesicles and called dyshydrotic eczema. In the following picture, we see lamellar or discoid lesion, which tend to develop on the extremities in children and adults with atopic dermatitis. It simply appears as a coin-shaped eczematous plaque, usually 1 to 3 centimeters in diameter, with a prominent oozing and crusting. So they are just similar to lamellar dermatitis occurring outside of the setting of atopy, but they could be part of atopic dermatitis. We have nipple eczema, and here that's important to differentiate it from Paget disease of the nipple. Now moving to the diagnosis. It's sole clinical diagnosis. Usually, no diagnostic tests are necessary to diagnose atopic dermatitis. So what we depend upon is the characteristic features of pruritus and chronically relapsing course of the disease, in addition to the supporting features that have been described. However, just to consider an individualized setting or based on individualized characteristics of the patient include allergy testing, IgE level, and a skin biopsy. So regarding the allergy testing, it might be beneficial in assessing the patient to avoid exacerbating allergen. However, up to 60% of children with atopic dermatitis will have no demonstrable IgE-mediated sensitivity to specific allergen. Examples of the allergens that are commonly tested for include the dust mite, pollen, grass, molds, animal dander, milk, and egg. Regarding the IgE level, early atopic sensitization have been associated with poor prognosis in patients with atopic dermatitis. So elevated IgE may be seen in up to 80% of patients with atopic dermatitis. However, it's not specific tests. Many other conditions might have elevation in IgE level. Regarding the skin biopsy, it may be used to differentiate atopic dermatitis from allergic contact dermatitis from psoriasis. However, it's less employed than a skin examination. Proper full skin examination would be more useful than a skin biopsy. However, it should always be an option in case we are suspecting the diagnosis or there is resistance to the treatment. So here we have the American Academy of Dermatology 2014 guideline for the diagnostic criteria of atopic dermatitis. So the essential feature that must be present in atopic dermatitis diagnosis will be pruritus and eczema that's characterized by a chronic or relapsing pattern. Typical morphology and age-specific pattern in terms of the distribution, it will be facial, neck, and extensor involvement in infants and children. Current or previous flexural lesion in any age group with sparing of the grayon and axillary region. Important feature that supports the diagnosis and observed in most of the patients, including the early age of onset, atopy, both personal and family history of atopy, and IgE reactivity in addition to xerosis. Associated feature that would be suggestive to atopic dermatitis, however, it's not specific, including atypical vascular response with facial pallor, white dermatographism, delayed blunt response. So how we can indicate white dermatographism, for example, is just by stroking the skin. This will indicate vasoconstriction. So we will have white discoloration over the skin. Keratosis biliaris, pityriasis alba, hyperlinear palm, ichthyosis, ocular or periorbital changes, and other regional findings, including perioral changes, periauricular lesion, perifollicular accentuation, lichenification, and periorbital lesions. So all the features we discussed as supportive features of atopic dermatitis. Here we have scoring atopic dermatitis, is a clinical tool used for assessing the severity of atopic dermatitis. It's used both before treatment to determine the severity of the disease and after treatment to determine the response of the disease. So scored system have three main elements, which is the extent, determined on the body surface area involvement, which will be different in children under 2 years old in comparison to children older than 2 years old. Second, the intensity, which will be determined based on six areas, including the erythema or redness, swelling, oozing and crusting, scratch marks, skin thickening, and dryness. And finally, the subjective symptoms, including sleep loss and irritability, which will be scored on a visual analog scale from 0 to 10. So 0 will be no symptoms at all, and 10 will be the worst symptoms experienced on the patient. So we can calculate this using manually, or there are multiple applications that you can download on your phone, such as Dermtol, that will have the scoring ready just for you to enter the information of the patient, and you immediately will get the outcome. So the calculation will be later based on this equation, and mild eczema will be, the severity will be determined to be mild if the score is less than 25, moderate if the score 25 to 50, and severe if the score is more than 50. Moving to the management, we have non-pharmaceutical treatment options and pharmaceutical treatment option. It's important to hint that doing the non-pharmaceutical measure is as much as important as doing the pharmaceutical measure. So we have avoidance of triggers, including irritants, allergens, and microbial agents, skin care that aim to compensate for the genetically determined impaired epidermal function. And we have bathing. So we have bath or shower once daily for 5 to 10 minutes in a warm water, no extreme temperature allowed, no extremely hot water, not extremely cold water, use of a fragrance-free or non-soap cleanser with a natural to low pH, then to apply moisturizer. The vaccination. It's important that all children diagnosed with atopic dermatitis be vaccinated according to the National Vaccination Plan. However, the vaccination should not be administered during acute flare, and the patient on immunosuppressive therapy with cyclosporin or unrelated medication should have a permission from their direct physician before having the vaccine. Important hint as well that intracutaneous smallpox vaccination with attenuated live vaccine should be avoided, as it is contraindicated in patients with atopic dermatitis because it will lead to eczema vaccinatum. So again, we have avoidance of trigger, frequent moisturization, bathing, and vaccination. Regarding the pharmaceutical treatment options, we have the topical treatment, topical corticosteroid, topical calcineurin inhibitor, crisaprole, and antimicrobial agent for secondary infections. Phototherapy, including narrowband UVB, UVA, UVB, and UVA1. In addition to systemic treatment option in terms of systemic corticosteroid, cyclosporin, azathioprine, MMF, methotrexate, tobalimab, omalizumab, tafasitamab, rituximab, and interferon gamma. So topical corticosteroid is the first line to treat acute flare of atopic dermatitis and used as a maintenance therapy to prevent relapse. Choice of the appropriate treatment, it will be based on the severity determined by SCORAD score, as we explained previously. The treatment will be divided into several categories, including treatment of the active eczema, maintenance of a hot spot, and maintenance of a low spot for all patients. So here we have a non-lesional skin. It will be skin care, again, moisturizing, warm bath, and the trigger avoidance. However, a mild atopic dermatitis determined by SCORAD score less than 25, it will be again skin care in terms of moisturizer and warm bath, trigger avoidance, and addition of antiseptic measures if there is susceptibility to infection or secondary bacterial infections. Similarly, in moderate disease, in addition to frequent application of maintenance topical corticosteroid, so it's either topical corticosteroid or topical calcineurin inhibitor. So we can utilize topical corticosteroid of low potency 1 to twice daily or medium potency corticosteroid once to twice weekly on all area except the face, or topical calcineurin inhibitor, pimecrolimus and tacrolimus in people older than 2 years of old, as once or twice daily or twice to thrice time weekly. In severe disease, here we come. We can intervene with phototherapy or systemic immunosuppressive medication such as dupilumab. Systemic immunosuppressive includes cyclosporine, methotrexate, MMF, azathioprine, and corticosteroid. Regarding the acute treatment, it will be initially with topical application of corticosteroid to the inflamed skin. The choice will be between low to medium potency topical corticosteroid twice daily for 3 to 7 days beyond the clearance of the lesion. So basically, we will choose the appropriate low to medium potency corticosteroid, allow the patient to instruct the patient to administer it twice daily for 3 to 7 days after disappearance of the lesion. Regarding the moderate and severe disease, we will have higher potency of corticosteroid for the same 3 to 7 days beyond the clearance of the lesion. If it's not resolved within 7 days, we can consider patient factors such as non-adherence or physician factor, including misdiagnosis or complications such as infection or contact allergy to the medication. So in conclusion, atopic dermatitis is a common inflammatory skin condition that affects up to 20 to 30% of children and 2 to 10% of adults. It represents a complex genetic disease with environmental influences and underlying defect in the epidermal barrier, as well as established immune dysregulation. Characteristic clinical features include onset during infancy or early childhood, intense pruritus, and chronically relapsing course. Acute inflammation and involvement of the cheeks, scalp, and extensor aspect of the extremities predominate in infants. However, shifting to chronic inflammation with lichenification and flexural involvement during childhood and adolescence. This is my reference, and thank you.
يعطيك ألف عافية دكتورة سكينة. Everyone attending, if you have any questions of Dictora, please, you can write them in the chat or in the Q&A, or I will be happy to read them to her. Dr. Sukaina, one of the attendees would like you to please repeat the point of vaccination and atopic dermatitis.
Okay. So about the vaccination, it's important that all children diagnosed with atopic dermatitis are vaccinated with up-to-date schedules. However, the exception will be in children who are on immunosuppressive medication, who should have a direct permission from their physician before having any vaccination. The other exception is smallpox, which is a percutaneous application of a smallpox vaccine, which may lead to eczema vaccinatum. So this considered as special circumstances, need direct permission from a physician and a special setting for application of the vaccination, or otherwise the kid might be complicated by eczema vaccinatum.
Thank you, Doctora. There's also another question. It's if I have an old patient with dermatitis, with lichenification and fissures, which topical treatment should I give him?
So it will be like the management of chronic atopic dermatitis. We will go to higher potency of topical corticosteroid. In acute setting, we will usually go toward the low to mid potency topical corticosteroid. In the setting of lichenification, we'll go to higher potency of corticosteroid with the patient.
يعطيك العافية دكتورة. برضو Mohammed bin Mariouf says, thank you for the great presentation. Could you please explain how phototherapy works in inflammatory skin conditions in general? Well, how does it work in atopic dermatitis specifically?
So it's basically the phototherapy will have immunomodulatory effects on the eczema itself. So in addition to reducing the additional symptoms such as the pruritus and the secondary infections. So it's immunomodulatory effect, it will modulate the immune response of the skin.
Another attendee asks, what is the prognosis of atopic dermatitis, I'm assuming?
So as mentioned previously, in infantile atopic dermatitis, we'll have about 60% of children or infants and children diagnosed before the 2 years old of age, clearing their atopic dermatitis by 12 years of age, 60% of them. However, the remaining 40% will proceed with atopic dermatitis until adolescent and adulthood.
Thank you, Doctora. The last question is asking, how would one differentiate between acute dermatitis and hives?
So basically, the primary lesion is different. When we are talking about hives, we are talking about the wheals, which will be like edematous swelling of the skin, or let's say it will be erythematous plaque. However, without the characteristic features of atopic dermatitis, including the fissuring, crusting, exudation marks. In addition, the hives that characterize like urticaria, it will be different in terms of their distribution, in terms of their timing when they appear, when they disappear. So slightly they will be temporary, appearing and disappearing within a 24-hour, and convergent to atopic dermatitis, which will be lasting longer. So the clinical picture, our morphology based, it is totally different between hives and atopic dermatitis.
يعطيك ألف عافية دكتورة. شكرا مرة على your time و answering all the questions.